Fetal circulation is a highly specialized system designed to optimize oxygen delivery to the developing brain and myocardium while bypassing the non-functional fetal lungs and immature liver. It operates as a parallel circuit heavily reliant on right to left shunting. In utero, the placenta serves as the organ of gas exchange. The fetal pulmonary vascular resistance is extremely high due to fluid-filled hypoxic alveoli, while the systemic vascular resistance is highly diminished due to the large, low-resistance placental bed. Oxygenated blood from the placenta follows a specific pathway utilizing three major shunts. The ductus venosus, oxygen-rich blood around 80% saturation, travels from the placenta via the umbilical vein. About 50% of this blood enters the hepatic circulation, while the rest bypasses the liver through the ductus venosus, directly entering the inferior vena cava. The foramen ovale, as blood from the IVC enters the right atrium, the eustachian valve preferentially directs this highly oxygenated jet across the foramen ovale into the left atrium. This blood then flows to the left ventricle and out the ascending aorta, ensuring the highest oxygenated blood reaches the coronary and cerebral circulations. The ductus arteriosus, deoxygenated blood returning from the superior vena cava, enters the right atrium, crosses the tricuspid valve into the right ventricle, and is ejected into the main pulmonary artery. Because pulmonary vascular resistance is overwhelmingly high, only about 10% of this RV output enters the pulmonary bed. The remaining 90% is shunted right to left across the ductus arteriosus into the descending aorta to supply the lower body and return to the placenta via the umbilical arteries. Transitional circulation. The transition from fetal to neonatal circulation is driven by two simultaneous dramatic hemodynamic events at the moment of birth: the removal of the placenta and the expansion of the lungs. Hemodynamic shifts. Systemic vascular resistance increases. Clamping the umbilical cord removes the low resistance placental circuit, causing an immediate sharp increase in systemic vascular resistance. PVR plummets. The neonate's first breath replaces alveolar fluid with air. The sudden presence of alveolar oxygen reverses hypoxic pulmonary vasoconstriction, causing massive pulmonary vasodilatation and a precipitous drop in pulmonary vascular resistance. Closure of the shunts. These sudden changes in systemic vascular and pulmonary vascular resistance alter the pressure gradients across the fetal shunts, prompting their closure. Functional foramen ovale closure. Seconds to minutes. The drop in PVR exponentially increases pulmonary venous return to the left atrium. Simultaneously, cord clamping decreases IVC return, dropping the RA pressure. When LA pressure exceeds RA pressure, the primary septum primum, is pushed against the secondary septum secundum, mechanically closing the foramen ovale. Functional ductus arteriosus closure, hours to days. The ductus arteriosus is highly sensitive to oxygen and prostaglandins. With the lungs now clearing prostaglandins and arterial oxygen tension rising significantly, the smooth muscle of the ductus arteriosus constricts. Blood flow reverses transiently left to right before the ductus fully constricts. Anatomic closure, fibrosis into the ligamentum arteriosum, takes several weeks. Ductus venosus closure, days. With umbilical venous flow abolished, the ductus venosus passively collapses and eventually fibroses into the ligamentum venosum. clinical implications of a failed transition. If the normal drop in pulmonary vascular resistance does not occur, the neonate remains in a state of persistent pulmonary hypertension of the newborn. In PPHN, right-sided pressures remain higher than left-sided pressures, maintaining right-to-left shunting across the foramina veil and ductus arteriosus. This results in severe hypoxemia that is often refractory to supplemental oxygen, as the deoxygenated blood continues to bypass the lungs entirely.